Right, ladies and gentlemen, I'd like to introduce our speaker for the night, who is a transplant consultant, transplant surgeon based at the Newcastle Hospital's NHS Foundation Trust, Mr Aimen Amer, and he's involved in something with the acronym ERAS, and I don't want to steal any of that thunder. He'll explain it all to you.
Thank you,
It's
John.
over to you.
Thank you very much. Well, good evening, everyone, and thank you for joining at this late time. Yes, I'm one of the consultant transplant surgeons at the Freeman Hospital, and it's always a pleasure to come and talk to the members of this charity, LIVErNORTH. I'll remind everyone that I am personally a beneficiary of the charity for well, it was 2019, wasn't it, John? When I was
yeah.
Sponsored to go and do a fellowship in King's College Hospital. So I'll just share my screen to show where we are with the enhanced recovery program in liver transplantation. How do I share screen? Share. Oh, disabled screen sharing. Would you mind enabling?
Done it now. Yeah, I've just done it. Is that working?
Let's see. Can you see my screen?
Yes, indeed. Everybody see it? Thumbs up if you can see it. Yeah, great stuff. Thanks, folks.
Okay. So yeah, so just one thing, if you do have any question at any point, raise your hand. I may or may not be able to see your hands going up. So John, probably rely on you if you see. I'm not ignoring anyone. If there is a hand up, please let me know. So yeah, so I'm giving this talk on behalf of the Newcastle Working Group for Enhanced Recovery in Liver Transplantation. And some of you, there are a few familiar faces in the audience today. Some of you will remember the original talk that I gave about the idea of enhanced recovery in liver transplantation. So apologies to you if there are one or two recycled slides here. They are necessary for what I am about to say after that. So just to start off with, this is a recycled slide, just to remind everyone what enhanced recovery after surgery, or ERAS, is in general. So this is a multimodal pathway. In other words, there are numerous components to the pathway that collectively lead to enhancing a patient's recovery after a certain procedure. I've just listed a few of these components. So preparing a patient and optimizing a patient before an operation, and that's a whole avenue in itself, but that's one of the components of enhanced recovery. The type of fluid that we give to these patients and how we deliver that fluid, and how to avoid giving too much fluid or too little fluid, again, is an essential component. The delivery of pain control to patients, and the delivery of pain control in a certain way that is not using one type of pain control on its own, but giving more than one type of pain control that act collectively to provide comfort for patients, but also to reduce the possibility of problems and side effects from one particular painkiller. So it's a multimodal analgesia regime. We try and reduce the time that plastic wear is inside patients. So all the tubes that we use during the operation, we try and reduce these, and we try and put fewer, and we try and remove them as quickly as we possibly can. And then physiotherapy is an essential, central component of an enhanced recovery program. Very, very active and very, very keen on having our patients mobilize as quickly as possible after an operation with a very targeted and focused regime, which is tailored to individual patients rather than a one-size-fits-all regime. And then the patients are involved throughout the journey of enhanced recovery, in every single step, from the very beginning, from the time we tell them about the program. As we consent them for the procedure, we continue that throughout the journey, so patients feel empowered and in the know. Okay. So,
sorry to interrupt. Can somebody mute their microphone, please, who's in the audience? It's giving a lot of feedback.
All right.
And there's someone's phone going off. I'm not sure who it is, but it's just interrupting Mr Amer.
I'll try and.
Thank you.
Okay.
Yeah, everybody muted. Great stuff.
thank you.
I appreciate that. Thank you.
Thank you. So just to the next point, why have an enhanced recovery program? And I thought I'd divide the benefits of an enhanced recovery program to three areas. The first area is the clinical side, and I put there that it reduces infective complications, but it actually reduces a number of complications, not just infective complications. Anything that would, if the patient stays too long in hospital, then they are more likely to develop clots in the legs, chest infections, infections in the wounds, so lots of things that patients could develop if we are not proactive with their recovery. And patients don't want to spend their time in hospital, let's face it. So what we're doing is we're looking at all the redundancy in their care, all the things that we think we're doing to benefit the patients, but actually they don't benefit the patients. Why leave a drain in for 10 days when it's already done its job by day 3 or day 4? So we're looking at all the redundant areas in the care of patients, and that may reduce the length of time that patients stay in hospital. It isn't the focus of an enhanced recovery program, but it is a byproduct of it, that patients end up staying lesser time in hospital, and then they can spend more of that time at home in their own environment where they would be more comfortable. The patient experience, we've seen this time and time again in enhanced recovery programs, that patients feel much better with an enhanced recovery program than without one. So the three experiences that patients mention the most are involvement in their own care, preparedness for what is to come, and they feel empowered because of all that, because they know what's happening, because they're prepared. They feel that they can speak up and say, look, you did say that on this particular day you were going to do this, but you haven't done that. It says so here in my booklet. And so there's the empowerment of patients to potentially, well, not necessarily challenge, but to speak up and talk about their care. Whereas the model we have now is one where patients will basically leave the care to their healthcare professionals, and they will just say, you're the experts, you know what you're talking about, I'll just sit here and be told. And that's a model we'd like to flip, so that patients are in the driving seat. And then there's finally the organizational side of things, because if you do get rid of redundancies, you are optimizing the use of the resources, and that's more important in the current day and age, in the current NHS, with the limited resources that we have. And it also means that the pathways are streamlined, so everyone knows what's going to happen on this day, what's going to happen on that day. And it means that staff know what's going on. They're not waiting for the individual surgeon to come in on that day and make a decision, because there are set criteria that we all know. So in other words, the surgeon is, or the anaesthetist, or the hepatologist have opened their book to everyone to say, look, this is the book I'm reading from. This is where I make my decisions from. It's available to everyone. And that way there's no discrepancy between what Mr. Smith does to what Dr. Jones does. We all know what we're doing, and it's not just based on my personal preference. We've all got a single hymn sheet that we're all singing from. So these are the benefits, generally speaking, of an enhanced recovery program. But it's not a new concept. It's been there since the 90s. The colorectal surgeons were the first to adopt an enhanced. Well, they so the surgeons, I think it was in one of the Scandinavian countries, developed an enhanced recovery program in colorectal surgery, and then it took on in many other specialties, and I've listed a few there. So it's not a new concept at all. And we have adopted enhanced recovery in kidney transplantation in 2020, and I presented our results to this group. And it's fully rolled out now. It was staffed through charitable funds, and we now have done over 150 kidney transplants through the new program. And you can see the results that we've got so far. So we've brought down the length of hospital stay from 12 days to 5 days. I had a patient yesterday who was begging to go home on day 4 after their procedure. Whereas back then you couldn't send a patient home on day 12 because they weren't ready at that point to go home. You can see the patient feedback. Everyone in the questionnaire that we sent felt empowered, supported, and prepared. And the staff feedback was quite high as well, bearing in mind that a lot of the results that we're getting here, 85% achievable within their role and 70% notice patient improvement. The remaining people felt they couldn't comment because it was sent generally to all the staff. So, for example, the theatre staff couldn't comment on anything related to the ward, for example. So there's a bit of a planning issue with that questionnaire, but I suspect the results are higher if you just focus on the relevant members of staff. And this, I'll just leave this slide there for you to read some of the comments we had from the kidney transplant enhanced recovery program. This is from patients and from staff. So the staff, the patient feedback is at the top, and there's some staff feedback at the bottom. Apologies, you might be able to hear my cat in the background begging to leave the house, so please ignore that if you can. Okay, I'll move on to the next slide. What about liver transplantation? Enhanced recovery in liver transplantation. I think in short, the answer is the uptake hasn't been huge so far worldwide. So I've got this map of countries that have published their work in enhanced recovery in liver transplantation. You can see a couple of centers in America. There's a few European centers, 3 of which have published their work in Spain, in France, and in Denmark. And then a couple of Chinese centers as well have published their work, and I've listed them at the bottom. So not many centers worldwide. And this is a paper that the Royal Free team in London had published, and it shows you what they've done is they've looked at all the other papers that centers have published and accumulated all the results. And what they've gathered was that the complication rate after liver transplantation, after enhanced recovery, is reduced, the mortality is reduced, and the length of stay is reduced. But as you may imagine, the readmission rate to hospital was increased with an enhanced recovery program. Now I have to say that you do find with certain enhanced recovery programs that the readmission rate is higher. Having said that, we haven't found that in the renal transplant enhanced recovery program. So despite the reduction in length of stay, not all programs will notice an increase in readmission rates. And again, just to highlight that there has been some activity in the UK, and what we're trying to do nationally is create a consensus on what should and shouldn't be included in an enhanced recovery program for liver transplantation. And we had the meeting almost a year ago now, and we're expecting the results of that, the consensus guidelines, to be published very soon. So, what I wanted to do now is share what we've been doing in Newcastle to try and create an enhanced recovery program here for liver transplantation. So we thought that the steps, the right steps to do this, which was similar to what we had done with kidney transplantation, was number one, to have a team and to make sure that we've got the relevant team members to move this forward. That's the first thing. The next thing would be to gather some evidence to know where we are and where we want to be, and then move on to the development stage and develop the pathway, and then apply it and assess it, and then repeat. And that way we create a pathway and fine tune it over time. So to start off with, the team, we have a multidisciplinary team involved. We've got anaesthetists, liver medicine doctors, we've got intensivists. So the difference between anaesthetists and intensivists is obviously the anaesthetists are the ones that put you to sleep, the intensivists are the ones that look after your intensive care unit. It's almost a similar specialty. They work together, but they are slightly different. We have nurses, specialist nurses in enhanced recovery, and ward nurses, nurses in the recovery area, nurses in theatres. And we have surgeons and other allied healthcare professionals. There's too many to name. There's dietitians involved, there's physiotherapists involved, there's pharmacists. So that's the team. And we have LIVErNORTH on board. So they are an essential element to the multidisciplinary team. We have representation, both John and Joan, and we have other members of the team as well who come to our meetings. So sorry, I was going to mention this, so maybe I'll just pause on that for a second, because I'm going to mention that in a bit more detail later. But we also have an enhanced recovery nurse specialist, and we have a group that facilitate quality improvement projects within the trust. The transformation and improvement team also on board and also help us through the development phase of this project. So what's our remit? Well, we are executing the first stage of the project, which is the data collection. We're in the second stage now, where we're designing the protocol and all the other aspects of the project development. We are obviously looking very, very closely at how this is going to be governed, and looking at it from a safety point of view. And we will be monitoring the progress of this project. We meet once every 2 weeks. Not all members are able to attend every meeting, but we do usually have a reasonable number of team members who will update the team on what they've achieved within that fortnight. And we have regular communication with people behind us. So, I will speak to my colleague surgeons. Louise, who's our hepatologist, will speak to her colleagues, and so on and so forth. And perhaps this talk here is part of that regular communication with the multidisciplinary team, because the patient side of it is an absolutely essential element. And so it would be very, very interesting to get everyone's feedback on what we've achieved so far and our trajectory moving forward as part of that development. So that's the first step, the assembly of the ERAS team. The second part of this was the data collection. So we needed baseline information. We needed to know where we are and what we're aiming to achieve. So one of the first things we were looking at was feedback from patients who have had a liver transplant using the current system. So that's a really important element, because we missed that when we did the kidney transplant enhanced recovery program. We looked at patient feedback after the program was implemented, but there was nothing to compare with from the past. So we didn't have the qualitative data that would show clear improvement in the program. We had 1 or 2 patients who told us that they've been through the old program and then had a second transplant, and it was much better the second time, but that's not enough evidence. So we wanted to get it right this time. We wanted to know what patients felt about the service that they're getting now. We also wanted to look at what we're doing now exactly. What are we achieving at the minute, and what are our actual numbers to then compare with later on when we change. And then we wanted to look at what the national practice is like, not just the Newcastle team's liver transplant practice, but also what everyone else in the country is doing. And perhaps that way we can look at areas of redundancy. So for example, if we are leaving drains in for 10 days and every other centre is leaving them in for 3 days, then that's an area we need to be looking at, just as an example. And obviously it's very essential to look at what has already been published. And as I mentioned earlier, nothing has been published yet in terms of guidelines, but other centres have published their experience. So we looked at that and took that into account. Again, I'm going to tease each of those areas separately. So the current patient feedback, we've developed a questionnaire about the current patient experience, and we will be sending that soon to our patients, both in paper format and in electronic format. And it looks at how patients are prepared now, how they're involved now, and how empowered they feel now. And then obviously, as I mentioned, we'll be using that as control data to compare it with what we do in the future. Okay, the next element of data collection was looking at our current practice. I think this is an important slide because I'll show you later on comparisons with our local data. So what we did was we audited all our liver transplants in Newcastle between March 2020 and October 2021, so a 20-month period. And I've just put some of the results of that audit in these bullet points. So we put 2 stomach tubes in almost 3/4 of our patients. We keep necklines in for at least 3 days after the operation. Patients stay on ITU for at least for an average of 3 days. Sorry, the necklines, again, that's an average, not a minimum. The medium time to removal of urinary catheters is 5 days, and drains come out on average 7 days after the transplant, and patients stay on average 2 weeks after their transplant. So those are our numbers. Those are the Newcastle baseline data. So then what we wanted to look at is what everyone else does. So we sent out an online questionnaire through SurveyMonkey, and this was done in collaboration with the ERAS for OLT, which is an organization that has created the guidelines that I mentioned earlier that will be published soon. And with the Liver Transplant Research Collaborative, we have meetings every fortnight with them on Mondays, and we ask them to tell us what they thought as professionals, what they thought of the survey before we rolled it out to everyone else in the country. So it was an electronic survey, and it was sent out between February and April of this year. And for the first time, we thought we would include all healthcare professionals, not just the surgeons. So we included the hepatologists as well, the anaesthetists, and the transplant coordinator to get everyone's thoughts on enhanced recovery and everyone's data on what they're doing right now. So that's what the aim of the survey was. We wanted to know what the current practice was and to understand nationally what the appetite was and the sentiment was towards enhanced recovery in liver transplantation. So the questions were tailored to each discipline. So for example, a coordinator wouldn't be asked what type of anesthesia would be used, but that would be a question relevant to an anaesthetist. And an anaesthetist wouldn't really know what type of follow-up we do for a patient, but a coordinator would know that. So the questions were tailored. And the respondents were asked to respond in the context of a straightforward transplant, not a complicated one. So because you could have multiple different answers. When would you take the drain out? How long is a piece of string? If it's a complicated procedure, you might leave it in for 3 weeks. But we asked them to answer in the context of an uncomplicated, straightforward liver transplant, just to get some baseline data. And then we analyzed it based on center and grouped it according to discipline. And you can see, this is a really interesting slide. This shows you that, so anything in red is definitely doesn't have an enhanced recovery pathway for liver transplantation. So you can see Birmingham, for example, no one in Birmingham, anaesthetists, hepatologists, surgeons, transplant coordinators, no one felt that they had an enhanced recovery program. Same with Edinburgh, Leeds, Kings, and Newcastle. Cambridge, interestingly, no one except for the anaesthetists felt that they had an enhanced recovery pathway for liver transplantation, but 83% of the anaesthetists who responded said they did have an enhanced recovery program. So maybe they have a limited enhanced recovery program just from an anesthetic point of view, but that is not a true enhanced recovery pathway because it's a multimodal pathway. It needs to involve all the components. So we are in the process of teasing out exactly what Cambridge had to be able to learn from it and potentially use it. The Royal Free, their hepatologists felt that they had an enhanced recovery program, but we don't think this is true information because the hepatologist's involvement has actually been minimal in enhanced recovery programs in general, and they were the lowest respondents. And actually, traditionally, enhanced recovery has been something that is mainly led by the surgeons and the anaesthetists with support from the physicians. So we don't think this is a true result, but we will interrogate that response further. So here's some interesting responses that we got. So the first response, if you don't have an enhanced recovery program, which many of the centers said they didn't, is your center going to, are you interested in performing one within the next 18 months? And these are the responses that we got. So you can see centers like Newcastle and the Royal Free and Cambridge, there was clearly an appetite to start enhanced recovery fairly soon, within the next 18 months. Whereas other centres like Leeds, for example, Birmingham, Edinburgh, and Kings, you can see there's some division there. Somewhere between 20 and 30% of the respondents in those centres felt that they would have an enhanced recovery programme in 18 months' time. But generally speaking, there was about 55% of all the respondents felt that there would be an enhanced recovery programme in 18 months in their centre. We then asked a very specific question about what would stop people from implementing an enhanced recovery program. So the boxes correspond to the number of people who responded. Most people felt that the complexity of the liver transplant recipient was the main reason why we still don't have an enhanced recovery program at the minute. And the other interesting point is that many felt that because there wasn't a standard protocol for it, that's one of the reasons why enhanced recovery liver transplantation has been limited in implementation. And that's an important point because that's where we come in. That's where we do the work to start an enhanced recovery program. Okay, so it sets the scene for what's to come next. We then asked, do you offer prehabilitation support? So things that would optimize patients before surgery. Do you offer prehabilitation support in the following domains? And you can see the commonest thing was nutrition. There is physical fitness as well, and optimization of chronic conditions. But then things like weight loss and psychological support and social care. We are very fortunate in Newcastle to have social care support, but it's not a thing in many centres to have social care in support for liver transplant patients. So that's really, really important to mention. Now, when we ask people, remember the response from Newcastle that I mentioned earlier, when it comes to inserting a tube down the stomach. We are a centre that regularly inserts tubes down the stomach. But if you look at other centres, for example, look at the pie chart on the left-hand side. Most other centres rarely or never put a fine bore tube in. So again, that was an area that was highlighted to us as something that we would need to look at. But the bigger tubes, the drainage tubes, most centres regularly inserted. Okay, so the next question is, when would you remove a urinary catheter? And these are only sample questions, by the way. I just thought I'd mention these because I brought up earlier what Newcastle does. So Newcastle would remove a urinary catheter on day 5, but if you look at all the other centres, these are removed much sooner than us. So maybe we are a little bit more conservative than other centres. Okay. On to the next slide. And what is the average post-operative length of stay for recipients in your centre? Ours was 11 to 15 days because it's in that bracket. We're 14 days to be precise. But that's, again, that can be improved. There are many other centres. About 45% of the respondents said that the patients stay in hospital for an average of 7 to 10 days rather than 11 to 15 days. So again, another area where we feel that there may be some slack in our proactivity in patient education, in removing lines, removing catheters, things like that. Okay, so if I go back to that original slide that I mentioned, what the plan was going to be. So we have assembled the team, we have gathered the data. When I showed this to some of the members of our team earlier, they basically were quite unhappy with this slide, and they said, actually, we've made a lot of inroads in developing the pathway, but I thought because we haven't completely achieved that, I've left that as still unaccomplished. But we are in the process of developing the pathway at the minute. So this is where we are. So we now have an evidence base upon which to work on. We have a multidisciplinary team that's involved, not just the core group, but there's a wider multidisciplinary team, and we are also collaborating nationally to ensure that whatever we do is agreed upon with other units. So I mentioned to you earlier the UK Liver Transplant Research Collaborative. That's one area we're collaborating in. We are also collaborating with other centres that have started an enhanced recovery or started developing an enhanced recovery program, and the other area that we're collaborating is with NHSBT, and I'll talk about that in a bit more detail later on. What we're doing is we're developing documentation that will help us go ahead with an enhanced recovery program. So we have a protocol that is shared amongst the multidisciplinary team, so everyone can look at and contribute to, and people can make comments on, until we have the finished article. And so we're almost there. We're going to be presenting that within the next few weeks to the rest of the team to get feedback and some form of agreement on the first draft of our protocol. There's also a patient journal, which I'll talk about in a bit more detail in a minute. And that is the patient side of things. That's what the patient looks at on a day-to-day basis. We also have patient information material, which Joan has kindly gathered a lot of data on. So looking at what other centres do. Peter is looking at that as well from our side, Peter Robinson-Smith, to see how we can streamline the patient education side of things before a transplant. So again, another area we are fine-tuning. And then flowcharts. This is for the benefit of staff. So staff can see these all over the wards and in intensive care. So it's really an aid memoir for people to look at when they are taking patients through the enhanced recovery pathway. So, so this is the protocol itself. So if you would log on to our shared drive, you can see this. It's a Word document, and everyone adds to it, almost like a wiki page. So you can add information, you can question parts of the protocol that other people have put in, and it's date stamped, so you can tell when the other person has contributed and at what time, so that you know whether it's something new or whether it's something old and redundant that you can change. So that's the first thing, the collaborative enhanced recovery protocol. We also have the patient journal. I'm giving you an example here, the kidney one, but the liver one will look in many ways similar to this. So it's got two sides to every page. There's the left-hand side. Sorry, the left-hand side shows you what to expect on every day, and the right-hand side shows you what the patient can contribute with. So that's almost like a scrapbook for patients to be able to input their their daily activities, what their weight was, what their target is, just for them to be able to engage. That now the clinicians don't use the information in the patient journal, but the patient uses it so that they can get into the habit of looking after their new organ. Okay. And there's lots of pages in there which, again, act like an aid memoir for patients to help them know what to expect. So, for example, this is the mobility program. So patients know on day one, this is what we expect of you: 2 to 4 walks, up to 40 meters. We expect you to sit out in a chair and eat. Now, that's not what's going to happen with the liver transplant, but we haven't agreed the specifics of a mobility program in liver transplantation, but it will look similar to that. Okay, and then this is what a flow chart would look like. This is for the staff, and this will be on the wards and in the recovery zones and in theatres. It will be a different one for each individual discipline, so not all the same. Can we achieve this? Yes, I think we can. We've got a dedicated team.
Oh, Aimen, we've got a raised hand from Hilary and David Yates.
Yeah.
Hilary and David, can you hear me? You'll have to unmute yourself.
Yes, I can. I'm unmuted.
Very good.
Just, I don't know if it's the right time because I don't want to interrupt in the thing. The only thing, I mean, it all sounds absolutely wonderful and all for it. The only thing that I haven't heard is about the poor old soul who's got all this information. They have their liver transplant and they don't keep up with all the targets that they're supposed to. Won't they feel a complete and utter failure, that they've let you down, and depression? Is there anything being thought along those lines? The people who don't keep up to all the things they're supposed to be doing and they're weeks behind, as it were.
That's an absolutely essential question. And I'm actually sharing this presentation right now, but if I can find the actual journal, for example, for kidney transplantation, I'll show you that what we show people is not, we don't call them targets, we call them sort of guides to aspire to reach, and it's made very, very clear in the journal that whilst some patients will achieve that, not everyone will, and it doesn't mean that you are falling behind. It just, every person will achieve that in their own time. It's more of a goal, something to aim for, but not necessarily.
In practice, my husband had a heart transplant 35 years ago, and we were all in Ward 27 at the Freeman in a very, very small area, and everybody knew everybody else. And somebody got rejection. And it was almost as if they they weren't playing the game. They'd had a transplant. They were really set to recover. You've got all the guidelines nowadays as to what they should do, what you're expecting of them. It's hellish if through no fault of your own other than your body, you don't quite. It can be very difficult if you don't meet, if you're expected to have these targets, and once of course you get behind and other things crop in, it's difficult psychologically to live with a transplant.
Yeah.
I'm just a bit concerned about that. That's all.
Yeah. So no, I can assure you that enhanced recovery in general is not target based at all. I mean, these are guide points rather than anything else. We don't use these to say, you know, this individual has to have this. And in fact, we don't really advertise it much to patients that, you know, this has to come out on this particular day. These are, you know, expected times, but we don't. What we do want out of an enhanced recovery program is that everyone gains some benefit. Our patients are completely different. I'll give you an example. So when we first did the kidney transplant program, we started with the living donor patients. So someone who's receiving a kidney from a relative, and those, generally speaking, tend to be fitter patients, younger patients with less medical problems, and we knew that they were going to do well, and the numbers were brilliant. But then when we opened it up to all kidney transplant patients, you then start to get the patients with more medical problems, and, you know, who are getting organs that are not necessarily the ideal organs, from which is what you would get from a living kidney transplant donor. By the way, you know, we're not talking the same thing in liver transplantation here, but in kidney transplantation, there is a difference between a deceased donor organ and a living donor organ. And then we started to see the differences in results between the two groups. But that, but in the protocol, we had already accommodated that. In the protocol, what we do is we look at where, you know, what we can achieve for patients and what we can't achieve, and where patients aren't able to reach targets, we just continue with all the other elements of the program that they can still benefit from. So if a patient, for example, for whatever reason, can't have their catheter removed because, you know, they have a long-term bladder problem, it doesn't mean that they come off the program, because there are so many other elements that the patient will benefit from, and patients will find that the other elements enhance not just their recovery but also their experience after the procedure. If the experience of patients in the kidney program was one of pressure, we would have seen that reflected in the feedback. But it was very, very clear. And please remind me at the end of this talk to share the full journal, so that you can see that it's made very, very clear right at the beginning that these are not set in stone. You are not expected every time to hit those targets. You're expected to know about them. You're expected to, you know, to aspire to reach them, but not necessarily achieve them every time. Not all patients will.
Because people are competitive.
Yeah, that's true. That's true.
Ill for a long time. If they've been ill for a long time, they presumably haven't been able to. This is me. I can get it sorted, and well, I'm just a bit concerned.
No, it's absolutely true. I mean, let me try and get back to the previous slide, because I want to confess. So, for example, this slide here tells you how many walks you need to do. I say you need to do how many walks the expectation is. So we would come to a patient and say, look, you know, let's try and get up. And you know, 9 out of 10 times the patient will say, do you know what? I feel like I've been kicked by an elephant. I do not want to move right now. And so what we do, and I, again, anecdotally, I found this to be very, very helpful. I have the conversation with the patients before they have their operation. So these conversations happen in clinic. And these conversations happen the day before the procedure, or you know, before the procedure. I would say to them, look, you know, this is how you're going to feel. This is how you feel right now, you know, very buoyant, very energetic, you're ready to go, but you're going to feel completely differently in a few hours. And I want you to remember how you feel right now, because there are lots of reasons why you're not going to be able to get up tomorrow. You know, one of them might be that you still got a tube in your throat and you're still asleep. But if you are awake, if you're in pain, tell us, because we're not going to get you up and get you moving if you're in pain. We need to optimize that first, which is another element of the enhanced recovery program. If you are feeling very sickly, then again, you know, we need to optimize that side of things before we get you out of bed. But if you're not getting out of bed because you don't feel like getting out of bed, I would ask you to remember how you're thinking right now, and not at that point in time, because you know, it makes a difference if you can muster the energy and try and get out of bed. Don't feel pressurized, but if you can, it will make a huge amount of difference in terms of complications and in terms of your actual recovery. And I brought this sorry.
Dr. Aimen, may I just interrupt very quickly? I had my transplant just over a year ago, and I have to say, I felt very pressured, not by any of the medical staff, but by the nursing staff, who seemed to have a level of expectation that I felt was based upon the renal pathway rather than a liver pathway. So some of the things they were asking me to do, I physically wasn't able to do at the time. And I suppose I agree with Hilary. My concern would be, how do you overcome that, and what education the nursing staff might have so that that doesn't happen again, because it was an unpleasant experience.
Okay. Now, I mean, obviously, you know, that's not what we want out of the liver enhanced recovery program. I think that is a product of the changing culture that we've had. In 2019, you know, we wouldn't move patients from their beds until the patients asked for it. And slowly the culture has changed, but we are in a danger zone at the minute where the culture is changing, and it's changing because of the renal transplant program, but we haven't got a liver transplant ERAS program yet. You can't just execute one element of the program without everything else with it. If we had asked patients on the renal side to move from day one without having everything else optimized at the same time, we would get exactly the same experience that you mentioned just there now. So we are in this, I mean, I don't want to be telling staff not to mobilize patients, because for me, that would be a step backwards. But I totally agree with you that if you take it in isolation, without the patient being optimized in every other aspect, then absolutely what you'll end up with is a motivated member of staff, not the patient, because you haven't optimized the patient at that point in time. So no, I agree. I think it's a difficult position to be in. So it's almost the program is threatened by its own earlier successes, if that makes sense. And that's why we need to get this program rolled out as quickly as we possibly can, but correctly. And that's why we're looking at the governance side of things, the safety side of things as well. And it's really important that we get the feedback that we're getting today. And we will 100% be discussing this at our future enhanced recovery meetings, just to mention that you cannot have one element alone without the rest. And we cannot be pressurizing patients. If we don't have the discussions early on, if you are not prepared for this beforehand, you know, it is absolutely unfair for you to be expected to achieve, you know, what is written on a patient journal in front of you, without. I mean, I can imagine you weren't even given a journal to tell you, because there isn't a journal for liver transplantation.
No. I mean, if it helps, Mr Amer, I'm very happy to come and do a patient story to the group to explain psychologically how I felt and physically how I felt, if you think that will help the process.
100% it will. I'm sure it will. I think people need to look at the the experience of the person who's going through the journey. None of us have had a liver transplant. None of the the healthcare professionals have had a liver transplant. We do obviously have members of the team, but not everyone's experience is the same. So yes, on this platform, I think this is an official invitation for you to come and talk to us. I'll speak to our enhanced recovery nurse specialist who organises the meetings to get you an invite.
Okay, Leanne has all my details. She has my email and everything, so I'm sure she will be able to give them to you.
That would be brilliant.
Yeah, that's great, Chris. I mean, this is one of the reasons that that Aimen wanted to have this talk, to pick up patient participation and involvement, and to smooth the way. So this actual, when it does come as a hepatology ERAS, surgery, it's going to be all the knobs are going to be knocked off it, hopefully, or some of them anyway. But I would like to think that Hillary's experience from 27 years ago, Hillary and David, that people might be a little bit more
35 years
35
ago, John.
well, that's
35
brilliant.
years ago,
35.
Yeah,
That's fabulous.
I don't think anyone in the transplant team now would think that an episode of rejection is a patient's fault at all.
Absolutely not. Yeah. So anyway, that's the purpose of the talk, and that's great that we're all getting some feedback.
And you'd be pleased to hear that I only have one more slide left.
All right.
But before, and hopefully you've got the raffle results.
Yes,
ready.
I have indeed. I have.
But what I wanted to say was that there is now a national appetite for enhanced recovery, and that's and that's what I have in my last slide here. So the umbrella organization for transplantation in this country, NHSBT, or NHS Blood and Transplantation, has set up a national enhanced recovery steering group to look at enhanced recovery in all transplant avenues, because we are really the last group to join the other surgical disciplines in enhanced recovery. And so they've endorsed this steering committee, and the goals, the aims of this group is to provide the tools and the experience to be able to implement enhanced recovery in all transplant centres. And obviously, we also provide the leadership on this, because we have the experience, we've done this before, and we collaborate with other networks, with other groups. I've only mentioned a few, but there are many, many other groups that we collaborate with to try and fine-tune the enhanced recovery pathways across the country. We have 3 work streams at the minute happening at the same time. So the first one is actually the tools and the resources that are needed for each centre to be able to implement an enhanced recovery programme. And I'm leading on that work stream nationally with a colleague of mine, a nephrologist in Belfast, Ashley and Courtney. There are 2 other work streams. There's the education side of things, and there is how we evaluate an enhanced recovery pathway when it is implemented in an individual centre, and when do we say it's a success or it isn't. And so far we have 4 members out of the 11 members of the steering committee from Newcastle, and I think that's a reflection of the work that we've done over the past 2 years. And then just finally to let everyone know that it's not going to be a national steering group that looks immediately at liver transplantation ERAS pathways, because that's still cooking in the background, as you can see from our work in Newcastle. But we think that kidney transplantation pathways are more mature, because there's at least 4 centres now in the country that have an enhanced recovery pathway in kidney transplantation. So the first year we'll be rolling out kidney transplant pathways across the country, and then hopefully by the second year we will have some experience in centres like Newcastle, Edinburgh, and the Royal Free, which we can use to create this blueprint for liver transplant enhanced recovery pathways elsewhere. there's always going to be hiccups in pathways. There's also going to be setbacks and areas that need improvement. And that is why we absolutely have to nail the evaluation side of things. So implement and reassess, and that is a continuous cycle. We are still doing it in kidney transplantation to this very day. And it certainly won't be any different for liver transplantation. So thank you very much, everyone, for listening. Thank you for bearing with me while you're all waiting for the raffle results. And hopefully we'll be able to hear that first before anyone takes questions. I'll stop sharing my screen now.
Well, we've got Yvonne for a question first. Let's have Yvonne's question. You're muted, Yvonne.
Not very often I'm muted, John, but thanks ever so much. Yeah, and that was absolutely a fantastic talk, and thank you so much for that. I was just wondering, bearing in mind just the things that are coming through there, with certainly what Hilary said and something on the chat as well, that Linda's alluded to. I'm sure, I mean, at the beginning in the first few slides, you mentioned some of the people who were involved, i.e. the hepatologist, the anaesthetist, etc., etc. In some of the hospitals, they had the health psychologist. Now, I haven't seen any. Am I missing something here in the procedures and the processes that you're going through? I haven't seen a health psychologist mentioned on any of the slides for what we're looking at in Newcastle.
So we have a health psychologist that helps us in our multidisciplinary team meetings. We admittedly do not have a health psychologist dedicated to liver transplantation, purely because of the small numbers that we do. But we have a health psychologist with an interest in liver transplantation who does come to our meetings. You've hit the nail on the head, and this is an issue that is not limited to Newcastle. When the meetings, the consensus meetings were taking place in January of this year, so almost a year ago now, one of the points that were mentioned were how few centres had a dedicated liver transplant health psychologist. And I think that centres that do have them are incredibly lucky, because they contribute a great deal. If you looked at there was a slide there which showed what pre-op interventions happen. You'll see that the psychology element of it is sort of somewhere in the middle, closer to the not available side of the bar chart. So no, it's not a common thing, and because our health psychologist is usually engaged in other activities most of the time, we haven't been able to secure a health psychologist regularly on our multidisciplinary team.
Okay.
That's good. Are you all right with that, Yvonne?
Yes, indeed. It just shows obviously the need, because the two questions that have been mentioned, one in the chat, a comment in the chat, and certainly by Hilary, the need for a health psychologist is pretty paramount, really, isn't it? Yeah. Yeah.
Absolutely.
Thanks, John.
Yeah. Okay. So Hilary's got a hand up first, then Chris.
I'm just saying that the heart transplant unit does have a psychologist, very much on a part-time basis. I obviously don't know, and the likes of the people here will know better, but I would have thought that some of the transplant problems are universal, to irrespective of what organ you have, whether it be heart, liver, lungs, or whatever. I'm wondering whether you can poach from the sorry, politically incorrect, whatever word you like.
Whatever word you want.
I'm wondering whether the already established transplant psychologist in the heart and lung transplant area could be, as it were, enlarged so that it would become a bigger department obviously, I mean, it's not, the Freeman is a transplant centre of all sort of organs of the body. And I'm just wondering whether that might be a helpful way to pursue that. As I say, I would have thought that the psychological problems dealing with somebody who's been very ill, who actually now, you would hope, is not very ill and is certainly on the road to recovery, those problems of adapting to that, I would have guessed, would have been very similar, irrespective of the organ that had been donated and transplanted.
So, so the short answer to your question is absolutely. If we could consolidate the resources that we have, the human resources that we have, of course it will benefit.
Better than poach.
There's no doubt about that. But, and there's a massive but here, in practical terms, it is almost impossible to cross that boundary in the NHS. So bear in mind, Hilary, it's not just the health psychologist, the physiotherapists, the heart and lung team have a full-time physiotherapy team dedicated for heart and lung patients. We don't in liver, pancreas, or kidney. Pharmacists is again a very, very similar story. And if you look at every single one of those allied healthcare professionals, it's the same thing. They'll be funded by a group
separately,
and that group will be quite protective of the person's time. And it's quite surprising how bureaucracy can get in the way, and it's quite clear to us here that if you share the resources, everyone will benefit. But if I poach an individual from another unit, the expectation is that our team would have to pay for the additional hours. And that is where the resource problem is, because these are recurring costs, and we struggle. We do struggle to, if you look so far, I'll give you an example. Our physiotherapists are still being funded through charity funds, which will run out in April, I think, or May next year. The same thing for our enhanced recovery nurse. So we have personnel who are at risk of losing their jobs within a few months' time, simply because the directorate cannot fund the recurring costs for those individuals. So there is always this problem, and I think in the current economic climate,
it's going to get worse.
It's going to get worse. It's definitely going to get worse.
That's sad.
It is.
Is that okay, Hilary? I mean, it's not the answer you want.
It's not okay, but
no. I mean, the third
sad.
We've offered to help as a third sector contributor, and we're trying to find out ways of doing it. So we're part of the ERAS team.
Chris, before you ask your question, so can I just share the journal, because I was good.
Yes.
We just got Chris for one more question, but do you want to take that now? Yeah, Chris Woodgate.
I was just going to reassure people to say that having the social worker on the team, on the transplant team, both pre and post, is invaluable, and she fills in that space that a psychologist would take. So where her expertise lasts, she will direct you to where you can find help or get help. And having used her a large amount following my transplant, and in throughout the subsequent year from my transplant, the help is amazing and it's great. And actually, I don't think you gain much more from having a psychologist, to be honest.
Well, that's good.
I mean, Chris, I completely agree. I think we are very critical of ourselves, and that's healthy, because that's how you improve. But sometimes, there are things that we have that many other units don't have, and it's a privilege to have. And having someone like Leanne in our team, which isn't something that other centres that I've been to and worked in do have, is something to cheer about. So I completely agree with you. And Leanne does that thing. She she fills in the gap in many areas, when it comes to liaison psychiatry or liaison, alcohol services or drug dependence, the links when it comes to, housing and benefits and all these amazing support we get for her. And she's a central member of our working group.
Good. That's that okay then, Chris? Yep.
So I'm just going to share the journal with everyone. Can you see that? This is the PDF version. I don't know if it's the most recent version or not, but it's just the one I could quickly find when I Googled. The ERAS journal. So if you look at the first page here, this is the first thing that a patient will read. Tells you a little bit about what enhanced recovery is and what to expect, and almost signposts you to pages that you can go to straight away. And then this paragraph here is the bit that I wanted to draw your attention to. So some patients might struggle with elements of the program. Don't worry if you don't meet all of your targets. Every patient is different, and the team will support you to achieve your targets at a pace that is right for you. The transplant team will adapt the program where needed to ensure that you receive the high quality care you need. We will not discharge you from hospital until both you and the transplant team feel that you are ready. And then it goes on, obviously, with all the details.
Excellent, excellent.
But we can't have a half-baked program implemented. I really feel uncomfortable going back to the team and saying, look, guys, you need to stop getting patients to go home early because we've worked so hard on changing the mentality of the team. But it is a threatening point in time where we want things to progress, but we're not quite there yet. And I think, unfortunately, Chris, you've been almost a victim of that success because we haven't established the full program at that point. Had you received a journal that said that to you, you would say, well, actually, I'm not ready yet. In fact, you might have been ready if everything else was optimized and if people were talking to you throughout the program, because there is a dedicated team that looks after the enhanced recovery program, and it's not just being cherry picked. We're not cherry picking certain elements of it doesn't work in isolation. It just doesn't work.
I think probably to the nurse's disadvantage on my own, I have worked in the NHS for 36 years. And so I had a level of expectation that fell a bit short, and they're not to blame for that. And I don't think I was either. It was just one of those circumstances. And I had a bad reaction to the operation, and mobility was really difficult. And it was just a set of circumstances, which is why I'm happy to share my story so that people can learn and see and understand. And hopefully, because of my experience at the NHS, I was qualified as a radiographer, was a radiology manager, and then at the James Cook Hospital, I was a divisional director. So I've been at every level and know how to speak to people at each level. I'm very happy to come and share that experience if you think it would be helpful.
We would be delighted to hear your experience, Chris. We know that liver transplant patients are a completely different group of patients. You've seen from one of the slides there why specialists have been reluctant to introduce enhanced recovery in liver, why we're the last members to join the ERAS party. It's because of the complexity of liver transplant patients, and that is why we need to get it right. We can't just apply enhanced recovery like that as an off-the-shelf package product and expect that it will work with liver transplant patients. There's so many complexities and so many potential complications that can happen. I mean, we quote a 20 to 30% chance of developing a complication of any sort, where anything from a small wound infection to, the biggest of complications. So it's not unlikely. And that needs to be factored in. We need to factor in when patients can can be not necessarily suspended, but their pathway can be amended to suit them and to work around any potential complication that they develop, which are more likely in liver transplantation.
Excellent. That'd be a great talk, Chris. I would mind sitting in on that. That'd be good. So thank you so much, Aimen, for your talk. It'll be recorded. It is recorded, and it will be available on our YouTube channel, and I'll inform people on social media and by email when it's ready to view. So I'll stop the recording now, if you don't mind. There was someone who did want to join after we'd started recording, but we couldn't let them join as I hadn't asked their permission so unfortunately they couldn't join us. Anyway, I'll stop recording now, but we'll continue the meeting.